shoulder flexion, or joint mob to improve elbow flexion. That's what the bicep does, correct? It could be three things is what I'm going to ask you to do. And of course, a question to know that you just didn't memorize, but yet you understand. So 2 to 3 activities and a clinical question. That's what it's going to be. It's going to be quick. If you know how to stretch the bicep, teach the patient, you do it. How to strengthen all forms using all kinds of paraphernalia that we practiced. If you know how to do joint mob to improve range, if you know how to do passive range of motion, like the first thing on the patient, then it should be quick. We're assuming you don't have to do hot cold, right, Mr. Mitchell? No hot cold. You don't have to question the patient, assuming it's all good. Just go and do it. But if there's stretching, you must teach the patient. Oh, you're filming. You must teach the patient if it's a self-stretch. If you're doing a joint mob, you must explain what you're doing to them. The patient is part of it. The patient is not just a dead body, right? All right, let's go. Let's get into the joint mobs. That's just all the rules of what we have to do. It's not working?
You broke the clicker?
No, it's not freaking off. It's just that anyway, let's start, shall we? I'm gonna X out of this. So let's start. I wanted to have it on the overhead, but Google Chrome's not coming up. There it is. What else? We have to let fill this dead time. It's very uncomfortable. Okay, so somebody say something. Please.
What did you do during the holiday?
What did I do during the holiday? Great question. It's none of your business. Where did you eat? Oh, yes. So the Jewish New Year, the world was technically, if you believe it, created on the Jewish New Year. So this is the dawning of the time, not only the dawning of time, but also between now and Yom Kippur, another day off. We're filming this. Don't send it to the rabbi. We are judged. God, this is not imposing religion. This is just what it is. You are judged whether you'll have a good year or a bad year, whether you'll live or you'll die. So between now and Wednesday, I am, if you believe it, are pretty much fighting for, again, if you believe it.
So does that mean you only have to behave for this week?
That's what got me kicked out of my first Jewish year. Yes, Phil, I'm fascinated with religion, actually. It's the coolest thing.
Really?
Yeah, religion's cool. It's just a cool thing. I mean, explaining things we can't explain. That's what religion is, right? All right, enough on that. Let's talk about things we can't explain. Joint mobilization. All right. Now, is this going to work now, Ryan? All right, so joint mobs. Let's hope it works. Enough of okay, so joint mobs. You understand concave and convex.
Yes.
Thank you.
Relax. You understand concave and convex? That is the key. What's up? How's the gut?
It's good.
We're good. All right. We'll catch up on everything. You understand the 4 grades. Do we any questions on the 4 grades? No? We understand the 4 grades? Kind of. You'll get better at it. Grade 1 and 2 is always to address what?
Range of motion.
No.
Oh, wait.
1 and 2 is
Pain.
always addressing pain. Grade 3 and 4 is always addressing range of motion. If the patient has a lack of range of motion and the issue is because of pain and the joint is the culprit, then you're doing grades 1 and 2. If the patient has a lack of range of motion and the joint is the culprit, but the issue is not pain, but yet tightness in the capsule, then we're doing 3s and 4s. Right? Correct. 1s and 2s, 3s and 4s. Good. Please know that. Moving right ahead, right along. So now we're going to go through joint mobs to improve range of motion or to address pain. Okay? Good. The first one is the shoulder. I don't have a model of the shoulder, but we'll work the shoulder. We do kind of have a model of the shoulder. Here's the shoulder. So we are working right in here, in this area. Okay? Working right in here. In there, right? You can do so many things. Remember the orthokinematics versus the osteokinematics, right? Which is which again? Osteokinematics is what you see. Arthrokinematics is happening in the joint. If I do shoulder flexion, you see clearly that the limb is going up, but look at the joint. The head is going down. The opposite, because it's convex moving on concave. So if I want to improve flexion, or extension, or external rotation, or internal rotation, I must do the opposite of what I see. For those of you not here for that lecture, that's you guys, right? Come talk to me, or talk to your friends. Okay, so let's start with the shoulder. Who's gonna be my first victim? That's not a good sales pitch. I need somebody to give me their shoulder. It will not be painful.
We always get paid.
Dennis, do you want to watch, or what's better for you? Because you kind of missed the lecture. Is it better to watch or better to be worked on?
Worked on.
Okay, then come. Okay.
You can always watch it later.
Did you shower? Did you put deodorant on?
did.
Because my hand will be getting in
Yes.
there,
Oh, well, that's good.
like literally getting in there. Okay. All right. So the first one we're gonna do is general distraction. Remember we discussed the general distraction, right? It's good for the joint in general. You could do 1s, 2s, 3s, and 4s for distraction as well. All right. Lie down, sir. Let's lie down here. Everyone gather around. Lie on your back. So, for general distraction, we always, and when possible, we'll start in the resting position. Okay? As you can see, what's the resting position for the glenohumeral joint? It's right up there. Right? 55, right? If this is 90, this is about 55. 30 degrees, this is full horizontal adduction. This is about 30 horizontal adduction, and slight external rotation, right? The thumb tells you external rotation, that's about slight external rotation. I wanna make sure the joint is off the table, and even a pillow, a towel under the joint, so I really can work the joint. The table will not impede my movement. I'm gonna stand in here, because I'm doing a distraction, right? And which way did the distraction go? As you can see, it's on the diagonal, you're right in front of the screen. Yes, yes. I know it by heart, so no big deal. So you are following the thumb. So if you put your thumb right in the joint, right? I just follow the thumb. I'm going on, are you ticklish? You're going on an angle, okay? So resting position, my hand is very nice and easy. I'm holding him here. I'm standing in here, and I'm doing a distraction, right? Again, I feel the full range of the joint. I'm not going up, straight up, no good. I'm doing out. I should see no shoulder elevation. That way, okay? I am feeling the full range of the joint, and then I'm taking up the slack, right? I assess by the full range, that's the patient's full range. I then relax. I push until the patient pushes back. That is where the 1 is. Remember, 1, slight oscillations at just where the slack is taken up. If I want to do 2, again, I'll feel for the full range the joint has to offer. I'll relax, I push till the slack's taken up, and then I go from that point halfway through his range, right? There's no oscillations in a 2, and it's a big movement. What do I mean by big movement? 1s and 4s have this oscillation, right? I do not want to let go, otherwise I never take that. So once I give up the slack, I keep it there. I'm moving from where the slack is to halfway, correct? 3 is halfway to full, right? I'm never going back to where the 1 is. And 4 is at the end, oscillations. Do you feel a difference in all those? Mm-hmm. Good. If you have the proper gut, not everyone does, I could do a distraction and just hang out here. I'm turning. As I turn, you feel a distraction? Mm-hmm. My hips are turning, and that also creates a distraction, which is good because once I have the distraction, I then could do other joint mobs. But that is distraction. 1s and 2s are for what?
Pain.
In what range? Which range does it help? Distraction. It's general, because a distraction is just a distraction. I'm not working in one specific range. So distractions are good, 1s and 2s are good for general pain in the joint. and 3s and 4s are good for general range of motion increase. Got it?
Got it.
So that's it. I go right in there, thumb up, resting position, I follow the thumb. My thumb is not, again, my thumb is at an angle. I am going at the angle. All right?
Are you pulling with the other
Huh?
arm? Are you pulling at the elbow or just stabilizing?
Oh, here? No, I'm just stabilizing it. I could even turn the hip and get a distraction as well. Yes,
You all do the oscillations only in grade 4?
1 and 4.
1 and 4. Okay.
How do you know? You weren't at the...
No, because you just said.
Yes, 1 and 4.
No, that's fine.
Yes, oscillations are grade 1 and 4. 1 is the slack is taken up, oscillations. 4 is the end range oscillation. I want to see oscillations in 1 and 4. I want to see big movements in 2 and 3, but not big enough where the slack is gone. That makes sense, everybody? Let me have a step stool. All right, next. So that is distraction. Now, if I'm doing posterior glide, right? Anterior to posterior, meaning that I'm anterior pushing posterior, correct? What does that improve? Anterior to posterior glide.
Flexion.
Flexion, because if you do flexion, you see up. The head is going posteriorly or down. What else? Thank you. Internal rotation, look. As I'm doing internal rotation, it's coming that way or up, and the head is actually rolling backwards. If you don't see it, look at it. Do it on the Allens, do it on the mannequin, or do it internal rotation. Show everybody. Start from the beginning so we can see it.
Okay, so bring it in.
Go into external rotation. Good, now watch. Internal rotation, you see the head is rolling back as the arm is going down. So that's why anterior to posterior will help with internal rotation and help with flexion. Make sense?
Yeah.
Is
Good.
it not rolling forward? Can you do it again?
Look at,
The head of the humerus, right?
look. It eventually will roll forward if you let it keep on rolling, but it's going backwards to forwards. It's going this way.
Clockwise. The head.
Yeah. It's going anteriorly, right?
Yes, but it's first going posteriorly. It's a circle.
Yeah.
It's going this way. So eventually, yes, it's going, I know this is not you, but when I'm doing internal rotation, it's going this way. So yes, eventually, if you can keep on making a circle, it will go anterior, but it has to first go backwards to go forward.
Okay.
Make
That's
sense?
a slow visualization.
Got it, Alan?
Yeah.
Good. All right. So that's why I'm doing anterior to posterior, okay? I'm in the resting position, which is 55, not 90, right? 55, slight external rotation, 30 degrees of abduction. Perfect position for me, right? I'm not going to take the goniometer out and see if you have all those accurate, but I do want to know that you know the resting position. And then I'm going to go in there, and whatever deodorant or after, whatever you use, it smells very nice. I must admit, you were ready for today's lab. I have this position. I'm going to do the distraction, okay? There's the distraction. I like to get my gut in there to keep the distraction. Here it's when it's not distracted. That's when it's distracted. Then I take my hand, I put it, I feel for the AC joint, okay? I don't want to push on the AC joint. The AC joint is so medial that I'm not working the joint itself. I'm too medial. Feel for the AC joint, just go just lateral to the AC joint. I don't use my finger. Did you get a black and blue mark?
Yes.
I'm sorry. I don't have
Honestly, I have.
As I did, I'm like, oh damn it. I'm not using my finger. It's uncomfortable. I'm using the heel of my hand, right? Or my hypothenar eminence, or my thenar eminence. Either, whatever works. And then I am feeling for the full range, and then I could do 1s, 2s, 3s, 4s. You got it? 1s, oscillations. 2, slack to halfway. 3, halfway to full range of the joint. 4, oscillations at the end of the joint. You must assess how the joint moves. Don't just do 1s, 2s, 3s, 4s. Know how the joint moves. Feel the full range of the joint. And then take up the slack and go there for 1s. You got it? So distraction. Put your gut in.
Hold that thought for a second. She needs your
Perfect word, distraction.
green face.
Sorry. It's just fine.
Okay.
You're in trouble.
Big
It's good to read what you're signing. If you're short, it's okay to put your foot on something or use these fancy high-low tables because your foot provides a really good base, but you're not using the base to stop the movement. You got it? Distraction. Stay distracted by putting your hip into the joint. Then switch and feel the range, 1s, 2s, 3s, 4s. You have to know when to use what mode to improve what range. Very important. You don't know how the concave convex thing works, and I do this to improve extension. I did not do a joint move to help this patient. Make sense? That is anterior to posterior. Right? Could you call it posterior glide, posterior mob, AP glide? AP meaning anterior to posterior. All right? Skip ahead 2. Question.
That's improving shoulder flexion.
Yes, do you understand how?
No, you
Because osteokinematically, as my arm goes
rolling
up,
backwards, then forward.
I'm rolling backwards, so I'm pushing that sucker backwards. Internal rotation, when I'm doing internal rotation, the head is rolling back. So I want to go posterior, use the words. My head rolls posterior, glides posterior, not rolls. Posterior gliding during flexion, posterior gliding during internal rotation. Therefore, I need to do a posterior glide to improve those ranges. Right? All right. Skip this one because the person's prone. We'll get back to it. Next. Inferior glide. I changed this to an easier one, but the inferior glide, the patient again is in the resting position. Slide. Now, let me go back and say one thing. If the patient had flexion only to 60 degrees and I do the range, and then the next time he comes in, now he has flexion to 100 degrees, where am I going to do the joint mode? Right, I'm going to do it here, in the new range. You want to chase the pain or chase the range. So resting position is a good place to begin, assuming the patient has pain. The resting position is the open packed, most relaxed. But as the patient gets better at his range, I'm going to do it at different positions. You could understand the concept, just get good at the resting position, but realize you want to chase. You don't want to just do at the resting position every time. You're not improving. You want to do it imagine a grade 4 at the end range. That really gets the joint moving. All right? Inferior glide. Resting position, right? And now, again, my hand, I'm feeling for the AC joint, lateral to the AC joint. I could easily move this gentleman's joint, okay? What I like to do for this one is to get the hip in it, I'm turning for distraction. So now I'm distracting that way. I turn and I push. So I'm not just doing it here, I'm pushing. I'm turning my body that way to get a good distraction. I'm feeling for his AC joint. I'm going lateral to the AC joint and I'm pushing straight down. Inferior glide improves what?
Abduction.
Abduction, because as I abduct, there's gliding that way, correct? The opposite of what the arm's doing, because it's convex on concave. So turn, and you feel it. Once I turn, his arm is primed for range. And again, assess the full range, 1s, 2s, 3s, 4s. His joint is off the table, resting on a towel. So I have full movement. Any questions on that one? Yes?
So when you're working on a new range, do you have to distract at the resting position and then go up, or you can
No,
just
so
start?
let's say now his abduction is here.
Mhm.
Now I just stand here, do distraction here.
Oh,
do the
so
joint.
you can start from there.
Yes, and if he's here,
Mhm.
then you have to be a little creative.
Right. Thank you.
Got it?
Got it.
Good. Next is prone. For an posterior anterior PA glide. Good, and this will improve what? Go back one.
Extension and
Go
external.
back, yes. Extension and external rotation, does that make sense?
Yes.
Because it's concave, vex moving on concave. As you do extension, the head is going forward. As I do external rotation, the head is coming forward. My arm is going backward, my head is rolling forward, gliding forward. You see that? If you don't see it, do it on the mannequin. Whatever that thing is. Just come to the side. I am now putting this towel on the coracoid process. Why the coracoid process?
Bony prominent?
It's a bony prominence. What happens when I press on the coracoid process?
Hurts.
It hurts. It hurts to the point that there's a special test for frozen shoulder. If the pain is more than 3 out of 10, then it's a positive test. The test expects pain.
Right, right.
So yes, you could create a lot of pain in the coracoid process. Maybe it's one of Mr. Mitchell's pressure points. You have to ask him. I'm just saying, you have to ask him. But the coracoid process is very, very painful. So for that reason, you definitely want to put a towel under the coracoid process. I can still do the resting position even though the patient's in prone, correct? 30 degrees of horizontal, 55 degrees of abduction, slight external rotation, and I'm ready. I put my hand here. Again, I follow the thumb to distract. I could rest my hip right there so it stays distracted. I take my hyperthenar eminence or thenar eminence. I feel for the AC joint. I put that eminence lateral, and I'm going straight down. The thing you have to really be careful for, does anybody know the prime body position for an anterior dislocation of the shoulder? No, 90-90. That's prime anterior dislocation. So I do not want to start cranking like this. Because that, not that it will, if the patient has a history and forgets to tell you that he had anterior dislocation, no good. So when you're pushing down, I like to make sure that that arm that is just hanging out, keeping everything in resting position, moves with it. Because if I start doing this, you feel the pressure in the anterior part of the, right near the pecto, the glenopecal groove, I think it's called, right there. So you want to be careful. So this is one where I make sure the arm that is stabilizing goes down as well. And again, I'm feeling the same thing. I feel the full range of the joint. I go down till I feel the slack is taken up. 1s, 2s, 3s, and 4s. Okay? Any questions on that? Good? All right, what's next? You still want to be the guy? You don't have to be the guy.
I think I'm good.
All right, everything feels all right?
Yeah.
You feel the joints moving?
Yeah.
All right, next is humeral ulnar distraction. Humeral ulnar distraction. So the patient is lying, you want to be the guy? Take off the sweatshirt. The patient is lying supine on the table. And again, general distractions, 1s and 2s are for to control general joint pain. 3s and 4s are to improve range generally, right? Good. So I am now distracting the humerus from the olecranon, the olecranon. My professor said olecranon. I will say olecranon forever.
Where are all these professors at?
No, it's one professor. It's my anatomy professor. This is how she pronounced. I'm not sure where she was from, to be honest. But that's how it was. Okay, so the resting position is very easy. For you, those of you who are young, this was, you remember Fonzie? Anybody watch a show on HBO? He's in it. The person who plays Fonzie. Barry. Anybody watch Barry? The old theater teacher? That's the person who played Fonzie. So you are at 70 degrees of flexion, about 10 degrees of supination. That's about like that. Fonzie hands. It's resting on you like this, right? My lateral hand goes right. My medial hand or lateral hand?
Lateral.
Thank you. My lateral hand goes right. I'm going to take a towel and rest it here. My lateral hand goes right into the groove here. My medial hand goes over. My elbows are in. And I am distracting. I'm doing this. Why are you so... I could, yes. I could just move you. So I'm doing a cupping motion to distract the ulna from the olecranon. But you have to do a cupping motion. Arms are in, and I'm just doing that. As you can see with my fancy picture, the cupping. All right, again, you could do 1s, 2s, 3s, and 4s. 1s and 2s are for pain, general pain when you're doing a distraction. 3s and 4s are for general increasing of range. You felt the distraction? There you go. All right, the next one is have a seat. Sit right there, looking down at Mr. Mitchell's desk. So move the chair. Have a seat. Good. Where is it? Here. I am doing dorsal and caudal, or glide this way or that way, as you can see in the picture, right? Right? This is the radial humeral joint. The good thing about the radial humeral joint, what's moving on what? If I move the radius on the humerus, what's moving on what? The radius is what?
Concave.
Yeah, but what is
Concave.
concave and what's convex?
Radial head is the
The
concave.
radial head's concave, perfect. So if I want to increase flexion, which way am I doing the glide?
Same.
Medial.
Medial, caudal, whatever, ventral,
Yeah.
that way,
That way.
that way, right? If it's ventral and dorsal. So I want to go that way to improve flexion
Oh yeah.
because it's concave moving on convex. As you can see, the radial head is concave.
Yes.
So I'm not doing opposite like the shoulder, I'm doing the same direction. Does that make sense to everybody?
Right.
Good. So I am feeling for the radial head. How do you catch the radial head?
Roll. Supination.
Yeah.
pronation.
Diana, put your hand right here on his radial head if you don't know where it is. Watch. Right there. Here.
I don't want
See
to
that
catch-
turning? That's, we discussed it, literally spins. So I just feel for the spin. It's right there, it's perfect. I'm taking my, it's a tweezer movement. I'm taking my tweezer right there. Right on his radial head. Here's his radial head. Here's this guy's radial head. Moving away all the ligaments. Right there, I'm doing the tweezer motion right here. And I'm just pushing with my thumb, or I'm pulling with my index finger.
Just a thumb.
Yeah, if I'm going that way, ventral, medial, whatever.
Yeah, ventral.
Ventral, I feel for the head. I put my thumb and index finger around the radial head. This hand is just resting at the joint line, and I am pushing. To improve flexion, right, I'm pushing. And I could do 1s, 2s, 3s, 4s. And then if I want to improve extension, I'm taking my index finger, and look, you can, it hurts.
It doesn't hurt. It's really like
It's weird, yes, because I'm controlling your joint. Watch, everyone look at the joint. Look at the radial head, watch. I am literally taking his radial head and moving it towards me. You see it moving? No, it shouldn't be painful, this feels weird. If the patient is huge, and his radial head is like, gonna win at the state fair, right, massive. In state fairs, they have contests, like the biggest contest. For those of you who've never been to a state fair, another great experience. I could take both thumbs and push. If his radial head is so massive, I can't control it. I could take both index fingers and push back, okay? But usually one is fine. I'm pushing ventral or dorsal this way, ventral to improve flexion.
Ventral.
Ventral, right? That's
Ventral.
ventral.
Yeah, ventral.
Dorsal or lateral to improve extension. That makes sense?
Posterior.
The heart is really finding it. Kevin has a very good radial head right there. Good?
Yes, sir.
Next. Good. And your body positioning and the patient's body positioning is very important. So now we're gonna do distraction for the wrist. I'm gonna put a towel right here. I'm gonna feel for the patient's, do we have a hand? Here, look. The carpal bones and the distal ulnar radius, right? One hand on the carpal bones, one hand on the distal ulnar radius, right? That is the joint right there. If I have them touching, put your hands together like this and make a fist with both hands. Do you feel that the muscles on the inside separate your arms?
Yeah, that's right.
You feel that? If you have them together and you squeeze, look, they come apart. So now I do the same thing on the joint line, and if I just squeeze a little bit, not a lot, you'll feel it coming apart, or you could literally just separate. Not enough to take one home with you, just separate a little bit. And then I'm going ventral or dorsal, or down and up. So if I want to improve flexion, am I going dorsal or volar? Sorry, this is the volar side of the arm. So am I going, let's make it easy. If the patient is like this, their palm is facing the floor, If I'm distracting and I'm going down to the floor, am I improving flexion or extension, and why? I'm improving extension. Why? Because if you look at the distal ulnar radius, that is concave. The carpal bones are convex. So if I want to improve extension, I am moving convex on concave. Therefore, I have to do the opposite. If extension does this, I need to do this.
Right.
If flexion does this, I need to do this. So I'm doing the opposite because it's convex moving on concave. That's why it's important you move convex on concave. Because you hypothetically can move the distal ulnar radius on the carpals, but then you'd be doing the wrong joint move. So, I see where the joint line is. This is where the movement is. One hand on the distal radius and ulna, the other hand, you can feel the patient's pulse also while you're at it. And the other hand right by the carpal bones, they're touching together. I separate to distract the joint. And then here's the trick though. A lot of students do this. That's not a joint mob. That is passive range of motion, right? If you do it right, do you see the wrist flexing at all? No, I'm doing this. You get it? I don't want to see this. That's not what I'm asking. Separate and distract. Distract and do a joint move to improve extension. Separate and come up to the sky to do flexion, right? If your hand is like this, then that's the opposite, right? Because now,
Yeah.
kind of. So make sure the palm is facing the floor. Make sure you are moving the carpal bones on the distal radius and ulna, and then you're easy. Down to improve extension, up to improve flexion. Distract, 1s, 2s, 3s, 4s. Good? Next, the hip. I want a really light person for the hip. That's small. How about small boned? Anybody?
Soy.
Somebody. Somebody. Doesn't have to be a female. It can be a male. All right. So the first one is distraction. What's distraction of the hip? What position am I putting the patient in?
Neutral.
30, 30, 30.
It's true.
Neutral or open pad. Yeah, so it's 30. It is 30. It is 30.
Yes.
That's about right, okay? My hands, I'm doing this motion like this. And I am putting one hand, one foot. This is where Mr. Mitchell should really come in and, help out. Because martial arts is it's all about how much weight you put on a leg, right? Right? Distribution of weight. It's all distribution of weight. Can anybody distract Sue Wynn's joint without moving her? Because I picked somebody who doesn't have a lot of weight on them because, right? Sorry. The point is but I did zero distraction. I just pulled you. The trick, but that's where sorry, I didn't mean to scare you. But 30, 30, 30, watch. I'm gonna do it again, watch.
She can hold on to the table.
She could, but you see, I'm distracting. Somebody, well, I'm not saying to be familiar, but I am distracting her joint. You feel a separation in the hip?
Darren.
She's also wearing really, really slidey pants. But that's the trick. So I'm putting my weight on the front leg, elbows in, and then I'm putting my weight to the back leg to distract. No laughing, please. For a distraction. The trick is to pull without yanking the person off the table. If you do it like this, your arms are working too hard. If you have a big person, like Kevin, I'll be tired after the third patient. If your elbows are in and your whole body's moving, then your small arms are not doing the work. Your whole body's working together. So you have to really get good at doing distraction without yanking the person off the table. And again, you could do 1s, 2s, 3s, 4s. Good? You good?
And that helps all.
1s and 2s, general pain in the joint. 3s and 4s, general range. Distractions don't work one specific range. They're general for the joint. Yes?
So you don't do the glide for the hip joint?
There are glides.
Oh, okay.
Ryan. So I changed this slide because the move I used to teach was harder. This is an easier move. So slide back. Thank you. You are crossing one leg over the other like so. If you're short like me, you're going to just put your body into it
Ah,
and push straight back. Much easier.
right,
I
right.
used to teach this, if you don't mind. Which does it also. I like it because you really get your body into it, but if you're not so tall like me and you have a big patient, it's very hard to do. This way, again, it's not your arms, it's your whole body. And I like to put my hand behind so I could feel the distraction. Anybody, whatever. You guys don't know who you're comfortable doing it with, but I feel the distraction. And that's how I'm gonna rate your 1s, 2s, 3s, 4s, right? I feel the full range, and then I feel it to the end slack, and I could do a 1 right there. Here's a 4 right there, okay? That's an easier one. Next, do you want one more? One more. You got one more in you? Good. The patient now is prone. Wait, so sorry. That anterior to posterior will improve what?
Flexion, internal rotation.
Just like the shoulder. Who would have thunk it? It's the same exact joint almost, ball and socket, right? To improve flexion, extension. Next slide, please. Thank you. Extension and external rotation. The patient's in prone. Okay. Where's my towel? I put the towel under the ASIS for comfort. I want to get to the humeral head. How do you find the humeral head?
Femoral head.
How?
It's up there.
Femoral head, sorry.
Oh.
At least I didn't call it TM. What, how do you do it?
Internal.
Correct, very good. So I do it this way. By the greater trochanter's right here. There it is. I feel the greater trochanter. Oh, you have this very prominent.
Nice, great.
And I'm supposed to go medially. Is it all right if I do this mode? You're okay? So I find the greater trochanter. Here's the humeral head right around here. Right? You're not feeling the humeral head move. You feel the greater trochanter move. Give me the step stool, please. Good. So I feel for the greater trochanter. It's right there. I go medially. It's supposed to be on an angle. And then my other hand grabs here. I'm like this. And now I am doing 1s, 2s, 3s, 4s. But I lift as I push. So I really could get a good move.
Ah, okay.
I'm not just keeping this here. It's a lot of work for me. If I lift as I push, then I get a really good anterior move. Fantastic. Okay? A bigger person, you have to really get the whole body working. Again, 1s, 2s, 3s, 4s. Assess the full range, take up the slack. Thank you.
It's going slightly impulse. It's not just going plain old anterior.
No, straight anterior is fine.
Just straight, okay.
Yes. Good. Any questions? Do you feel like you have a new hip now? No. Okay. One more session. Yes.
For the distraction, you also do 1, 2, 3, 4. right?
Yes, every distraction can be 1, 2, 3, 4.
So I think
You
when
pull.
you do 4, I think the patient's gonna slide down with you.
They could hold on. Usually I could get a good 4, but those pants are very slippery.
Right, right. And when you do the oscillation, you just
Yeah,
do like this from there.
yeah. So you're doing like this, but very light. Patients love it. You never have to worry about unless the patient has a serious history, hips do not dislocate. Hips do dislocate, but usually after a motor vehicle accident, not from your pulling.
Yanking off.
What's the number 1 distraction of the hip? What type? Anterior dislocation is number 1 for shoulder. What about for hip?
Posterior.
Posterior, how? A few ways, but the number 1 way is this. We're going on our road trip. I'm sitting like this.
Oh.
Oh.
You hit a car in front of me.
Oh, boom.
That's why my wife puts both her feet on.
No, put it down.
It's not good.
Oh, wow.
Yes.
Oh, that's why.
Well, even if you're sitting regularly and you get into a big enough accident, the front of the car goes right in there.
Right, right,
Yeah.
right.
So posterior distraction, number 1 for motor vehicle accident.
Oh.
What?
Oh, I had a hip reconstruction.
From it,
Motor
you had a
vehicle
dislocation?
Not dislocation, just a reconstruction, but yeah, that's what it
Maybe you'll share a story during the hip lecture, if you want to. All right. What's next? All right, we learned this one. Do you want to go over it again? We learned this one. Do you want to go over it again? How about we'll skip those only, and I'll be around to show those that don't feel comfortable with it, just in the interest of time. But I will help you guys specifically with those, but we practiced those for a while. All right, next, for the towel curl joint. Again, you want to be like this. Sorry, 1 foot back and do the joint. But we'll do it on a real person. Darren, do you mind taking off the shoe and sock? This is what it looks like.
Construction boots.
See, this is what we're doing. Here, hold on to this. We're doing this, look.
Big old shit figures.
I'm distracting the talus from the distal tib fib. All right, so the patient is here. You could be no, put your head there, lie down. Good. You could be standing or sitting, as long as you have good control. Again, it's the same thing. I'm really looking for good footwork, 1 foot behind the other. Also, even for the hip, right? If you're standing like this, doing a distraction, and something happens, you're falling right on your skull, and they're taking the patient with you. If I go this way, I'm not gonna fall. It's much better control, right? For example, I don't feel like pushing people around, but if a person standing like this, I could shove them over easy. If they're standing like this, I'm not shoving them over so easy. The same thing with your body. You don't want to have an accident where you're standing like this and everything falls. This way you're safe, and it's much easier to transfer weight. So, kind of the same position like this, right? Does my fancy picture have it? Yes. One hand over the other. I am keeping my elbows in, and I am distracting. I like doing the little cupping motion, like with in the Allkranen fossa. But yes, very good.
Good old crane.
And I'm starting my weights in the front leg, and I'm going to the back. Let's do the distraction. Good. Again, 1s, 2s, 3s, 4s. Distractions in general are for general pain relief or general range of motion. What's moving on what? If I'm distracting the talus on the distal tib fib, what is moving on what?
Convex.
Convex on concave. But this is why you have to be careful for the joint mobs if you're doing, because I can distract the distal tib fib on the talus. It's legitimate, but then that's concave on convex. And you're doing the wrong mob. Right? So if you're sticking with talus on distal tib fib, it's always concave on convex, convex on concave, and therefore if I want to improve dorsiflexion, then I'm doing what mob? Anterior, posterior, or posterior to anterior?
Posterior.
Anterior to posterior, right? Let's see if I'm right.
Yeah.
Posterior glide for dorsiflexion.
That's nice.
Right? Because dorsiflexion, the leg is going that way, but the joint is doing the opposite.
Right.
Right? But I have to make sure that I'm, a lot of times during, see?
Yeah.
The talus is going down as the toes go up. You just broke something.
No, it was already,
It was already
like
broken.
that.
It's all right. I won't tell anybody. Look, show everybody. As the toes go that way, the talus goes the other way. Talus is going that way while the toes go that way. You see it?
Right.
So I am doing a anterior to posterior glide to improve dorsiflexion.
That's pretty good.
Giving you the finger. That make sense? So,
I don't remember. Navicular?
you don't, that's not navicular.
This is a cute.
Cuneiform.
All right.
Middle.
All right, don't distract me with the bones of the feet. So I am taking, I don't care which one's which. If you're a righty, then your right hand is stronger. You can, what's the word? Stabilize with your left hand. That is holding the distal tib fib. What?
Remind me of Little Mermaid.
Oh. Distal tib fib, my hand on the talus, right? I am distracting, doing a distraction, and then I am doing an anterior to posterior glide of the talus on the distal tib fib. And I like getting right in there because my whole body's moving. So a little bit of a distraction and then straight down. All right, conversely, flip. If I'm doing a posterior to anterior glide, right? Because now he's on his stomach, so this is an anterior glide. You get it? Right? Next, you got the next one? And then I am now mobilizing the calcaneus, because the calcaneus is easier to grab onto. Stabilizing here, grabbing onto the calcaneus, distracting just a little bit. Hey, Dr. Engel. I'm distracting just a little bit, and I'm going straight down. 1s, 2s, 3s, 4s, straight down, right? And a posterior to anterior glide, a PA glide, will improve what?
Plantar flexion.
Plantar flexion, because it's convex surface moving on a concave, right? Talus,
Yes,
calcaneus together,
Right.
move on. That's it. So that's it. I could talk for hours, as any of you know, but the trick is for you to practice. And again, I am not going to be, I want to make sure for the practical that you know how it moves, what you're going to do. Proper patient positioning, proper patient comfort, your comfort, your positioning. Am I going to scrutinize your 1s, 2s, 3s, 4s? I want to feel them, but no one's going to fail for not getting the perfect 1s, 2s, 3s, 4s. But I will hold you accountable for knowing what glide to do to improve external rotation. And the patient has to be in the right position. Explain to the patient what you're about to do. Show me 1s, 2s, 3s, 4s to your best. Don't be nervous about being imperfect. It's really a life's work. If you have any issues on footwork, that gentleman will help you right there with footwork, as he has helped me many times over. All right, start practicing.